So welcome everybody to Healthwatch Oxfordshire webinar. We're hearing today about cancer and cancer care and what's available in the county. Really pleased today to have speakers from Maggie's Oxford, Mike Tadman, who is the cancer support specialist, Abby Odebayo, head of programs at the Thames Valley Cancer Alliance, and Coyote Fadina, who's the program manager for personalised care at the Thames Valley Cancer Alliance. So as Jazz says, we're going to hand over to speakers. Mike is first, and I think he's got some slides to share. If you can all remember to be on mute if you're not speaking. Thank you.
Thanks, Veronica. Veronica, I'll just try and share the screen now and see if we can get the slides shared. Okay, is that showing properly, Veronica? Great. So thank you, everyone. Thanks for letting me come and talk about some of the work we do here in the Maggie's Centre in Oxford. So my name's Mike Tadman. I'm one of the cancer support specialists here. My background is as a cancer nurse for many years and a cancer educator as well. And more recently, I've joined the Maggie's team here in Oxford. So Maggie's Cancer Support started with a concept from Maggie Keswick-Jenks, who's a young lady who had a breast cancer diagnosis. And when she was diagnosed in Edinburgh, she had an experience of being told about her cancer having advanced. And she had to sit in a corridor after that, and there was nowhere to go where there was a really lovely place to go and get support or information. From that emerged this concept of somewhere, a cancer support centre. So with her husband, Charles Jenks, and also her cancer nurse, Laura Lee, and the team, they came up with this concept of a cancer support centre. And the first Maggie Centre was opened in Edinburgh in 1996. The concept really is around somewhere where people can get cancer support, some form of cancer information, psychological support, emotional support, and to be done in a sort of beautiful, calming space. Maggie Keswick-Jenks was a designer and writer. Her husband, Charles Jenks, was an architect, and the concepts of the centre is built from their original vision. I'll look a little more of those in a minute. So looking at what happens in the centre. So the buildings are designed to be calm, friendly, welcoming places, and always full of light and warmth. And we see that on a daily basis when people come into the centre, that they may come in looking really stressed or distressed. And when they arrive, you can often see them calming, their shoulders dropping, and able to then sort of talk with someone in the centre. They all have a kitchen table at their heart, so they're always built around the kitchen, so the hearth of the home where people can sit and talk and feel at home. And they always offer glimpses and views of the nature that surrounds them. And they provide a thoughtful space to find privacy as well, and as places to come together as a group. Got a few pictures of the centre in Oxford. So this is the tree house, as we call it. So this is the Maggie Centre in Oxford, built in the grounds of the Churchill Hospital. So that's one of the outside views. This is our main room, which today is full of cancer nurse specialists who are having a course in psychological level 2 work. And this is our sort of main kitchen area, which is often full of people, but that's a picture very early on in the building's opening. This is slightly out of date. There are actually now 27 Maggie centres across hospitals in the NHS across the UK. So the idea is that they're each built in the ground of an NHS cancer centre. And the ambition in Maggie's is to have one at every NHS cancer centre across the UK. So the one in Oxford opened in 2014. As I say, you've got the first one there in Edinburgh in 1995. And more recently, very recently, in fact, there's a centre just opened in Northampton and one in North Wales as well. So what happens in a centre? So I think many people will know that they can come in and have support, but it's really important to understand that the cancer support there, that everyone in the centre is cancer support specialists. We're all either very experienced cancer nurses or radiographers. We also have psychologists. We have very experienced benefits advisors. Plus, we're also supported by our wonderful volunteers who will meet and greet when you come into the centre. So the fact that there's a very high level of professional cancer support's a really important part of the Maggie's ethos. So what goes on in a Maggie Centre? I've split it into bits, but I see this really as something that everything's really integrated, and people may well use various different parts of the support, maybe one part or actually all of it in a range of different ways over the time that they have a cancer diagnosis and treatment. So key element of Maggie's is this just come in. So you don't need an appointment. So people will often walk into the centre having maybe had an appointment at the Churchill Hospital, meet their oncology consultant, or have had chemotherapy or radiotherapy treatment, and they can walk in and be greeted by a volunteer and meet one of the cancer support specialists. And we'll talk to people about how they're feeling, what concerns they have, but also assessing their needs and so guiding them, informing them about other work that can happen in Maggie's. Often that initial assessment by itself is one of the most important things. It's where people can, for the first time, have space to really talk about how cancer is impacting on their life, and we can, have a important conversation with them and look at how we might be able to support in a range of ways, or signposting to how their team can support them, or other charities and other organisations. We then also run a series of workshops. So, for example, these would be one day or short courses of an hour or two, where we might look at mental health issues such as introduction to mindfulness. We might look at issues such as hair loss. We run a course called Health and Wellbeing, where we look at sort of preparing for treatment and the early part of treatment, and thinking around issues such as nutrition, exercise, and mental health. We also work with other courses, charities such as Look Good, Feel Better, who do these wonderful courses, not just focused on women, but often mainly focused on women, about looking at makeup and hair and doing the nails. So when people are going through treatment, how to, as it says on the tin, look good and feel better. We then run longer courses. So we have 4-week courses, for example, looking at post-treatment, how people are managing post-treatment, called Where Now. And one of our psychologists also runs a course on managing stress with a diagnosis of cancer. We work closely with other charities in the NHS, looking at things like network site-specific cancer groups. So, for example, I run a cancer group which supports patients with neuroendocrine cancer. If one of the leukemia groups runs out of the centre, and there's a range of other cancer site-specific groups. And then on a one-to-one level, we're blessed to have a counsellor and 2 psychologists in the centre. So we offer, if after assessing patients for their needs, if we feel there are specific high-level concerns or anxiety or low mood that needs work, we can offer counselling and psychological therapy. And last but certainly by no means least, benefits advice. It's often a really important part of the work we do in the centre, is giving people support around financial concerns with a cancer diagnosis. And this is how it all really fits onto this cancer patient pathway. So along the bottom, you can see a number of the courses that we may and support that we can offer. So the cancer support specialists, managing stress, activities such as exercise and relaxation, all the way through to family and friend support. And a key part, which I've maybe not made clear, is that this isn't open to just people with cancer, but the families and friends that are affected by this as well. And our work really goes right through from diagnosis all the way through to through treatment, to post-treatment, so such courses such as Where Now, and also patients living with advanced cancer, and to end-of-life support and some bereavement support as well. At Maggie's, I think it's a really key thing. We want to make sure that everyone has a warm welcome when they come in the door. It's such a key part of the work, both our cancer support specialists, but also our volunteers do. So every time that door is open, someone is always there to greet you. It can be a huge step walking across, from your an appointment where you maybe have just had some really bad news, really struggling with that information, and to take that step across Maggie's, knowing that it's going to be a really emotional time. That warm welcome is so important. Once you're in the centre, it's not just about a warm welcome, but also effective cancer assessment and support, so that we can try and offer support that's really appropriate for each individual and then is then bespoke to them. So as we say at the bottom, we're not just here to listen, but to guide, support, and empower people with cancer. Okay, that's all I need to say I'll just stop sharing.
Thanks very much, Mike. That's great. We will move on now to Abby, and I'll share her slides, and then we'll have discussion at the end. So thank you.
So my name is Abby Odebayo. I'm Head of Programs and Health Inequalities Lead with Thames Valley Cancer Alliance. And so this afternoon, I'm doing Kayode Fadina, who is the Project Manager for Health Inequalities. I'll be doing the double act in the presentation. But we've also got another colleague from Thames Valley Cancer Alliance, Lisa Cox, is on the call as well. And she's the Patient and Public Engagement Lead. So I'm just going to start. Apologies if I look sideways because I've got two screens. I'm just going to start by talking briefly about the Thames Valley Cancer Alliance before I then talk about the health inequalities work and specifically our Cancer Allies program. So Thames Valley Cancer Alliance was established in 2016, and this was following the publication of the National Cancer Task Force Strategy. And one of the recommendations was the formation of cancer alliances. So we are one of, so there were 93 recommendations there, and I think we are one of 32 alliances across the country. And Thames Valley Cancer Alliance brings together key stakeholders who are involved in cancer care. Think about providers, NHS trusts, primary care, PCNs, charity organizations, everyone, and even patients, patient representative groups as well. So we take a whole system approach to cancer services across Thames Valley. So so within the Cancer Alliance, we have 3 key areas of program, which is we have the early diagnosis program, we have the sustainable operational performance, we have treatment and personalized care program. So those are the 3 main programs that looks at the whole cancer pathway from diagnosis to treatment and end of life care. But in addition, we also have what we call our key enabler programs, and the health inequalities work is one of the key enablers. We have our patients engagement, our stakeholder engagement, so that's part of our key enablers. And our partnership working is aimed at securing and delivering the best outcome for the patients population that we represent. So our mission is really about improving experience of care and outcomes for our patients. And that's just a brief overview of Thames Valley Cancer Alliance. And we are hosted by Bob ICB, the Integrated Care Board. The other information about Thames Valley Cancer Alliance is that we cover the population of Buckinghamshire, Oxfordshire, West Berkshire at the moment, and also Swindon. So it's a bit of a strange one. We do cover that Swindon patch as well. So the Cancer Allies program. So what's the Cancer Allies program? It's a community partnership program that is designed to build long-term trusted relationships with organizations that we know are deeply engaged with our target populations, particularly populations underrepresented in cancer care, or the patient groups or the communities that are more likely to have a negative outcome in cancer services. So we work with community groups, we work with faith organizations, we work with cultural networks, grassroots leaders. So we have people we call our allies, anyone who can be a cancer ally. It might be someone who has influence within the communities we're trying to target in terms of our programs. So those are the kind of communities we work with. And the main aim of the work is to increase awareness of cancer signs and symptoms, is to support help seeking and improve and increase screening uptake across those groups, is to understand cultural practical and emotional barriers to accessing health. It's also to improve trust between communities and cancer services. So that's one of our aims, to see that increase in trust. So the core idea of the Cancer Alliance program is that the communities know what works best for them. So we don't come to tell them. It's more about seeking solutions, working in collaboration with this community, understanding that they know what works best for them. And it's not a one-size-fits-all approach, understanding that there are community cultural nuances and trying to, to have a discussion with the community to understand those and to develop tailored and targeted initiatives to see that improvement in cancer outcomes and improvement in experience of care. So our role within this is to listen, to collaborate, and to act together. Next slide, please. So in developing the Cancer Alliance program, the Cancer Alliance program was only developed between 2020 and 2021, following the COVID pandemic and obviously we saw a lot of the outcomes as it impacted certain communities and certain ethnic groups. So Cancer Alliance was born out of that. And what was the challenge? The challenge is that we know that cancer outcomes are not equal across all groups. And obviously we talk about health inequalities. We know that some communities face higher rates of late diagnosis, which reduces treatment options and actually survival, knowing that early diagnosis saves lives. We know that screening uptake is strongly shaped by not just awareness and understanding, but there's also trust and past experiences. There's also cultural perceptions. There's also language and communication barriers. And there are day-to-day barriers as well, including work schedule, childcare, transport. So we understand all of those challenges. In addition, we recognize that the groups most affected in our region, when we talk about Thames Valley, the groups most affected include the Black African and Black Caribbean communities, South Asian communities. Obviously now with the new arrival of migrants into the country, and also people living in the deprived areas are most likely to be impacted or to have lower uptake of cancer, as we've seen by data. So our work is very data-driven, as we've seen by data. We also know that people with learning disabilities, people with neurodivergence conditions are most likely to be impacted by this and to have lower uptake of screening. And so for us, the challenge is that if we want to see an improved outcome, it means we have to address both the clinical and the social barriers that shapes services. So the principles of the Cancer Alliance program is based on the principle of co-production. That's the key word there, is co-production. And because again, like I said, we understand that the communities actually understand the problems and are able to provide the solutions in a way that the healthcare, we as the healthcare organization cannot. So it's rooted in co-production. So we work with community organizations to develop targeted messaging shaped to local voices. When we started the program and we were doing some work with some community organizations to understand how to shape the Cancer Alliance, there was a key concept of someone like me talking to me about that, that building that trust with someone like me talking to me. So we understand that messages need to be targeted. Just because even if you're doing, say, breast screening messaging, it's not one size fits all. It has to be targeted to the population you're trying to actually see and improve in that uptake. So we recognize that one size doesn't fit all. We recognize that communities identify, because they identify their own barriers, they are much more likely to be able to provide the solutions. One of the key principles is to promote early action, that message that early diagnosis saves lives. So early action, and to reassure those communities that it is safe, it is worthwhile to seek help early. It's about building shared understanding and shared ownership over improving cancer outcomes. If you just move on to the next slide. Thank you. And this is my last slide before I hand over to my colleague Kayode. So this slide just talks about our methodology and the framework we are adopting in addressing health inequalities in Thames Valley Cancer Alliance. So our approach combines data, community insights. We believe very much in both quantitative and qualitative data. Sometimes the data doesn't tell you all of the story. And so we recognize that there's also that qualitative, empirical data, community insights patient experience, and collaborative design. So we start by understanding the community context. Then we develop the message, adapt the message, select the right messenger. So one of the other key points that came out of our initial work was that the message is as important as the messenger. And sometimes we focus so much on the message, but actually, even if the message doesn't go through the right messenger, it can miss the mark. So there's the message, there's the messenger, but there's also the platform. You've got to actually realize that if I'm trying to target breast screening for women at a certain age, where am I most likely to find them? And if it's cervical screening, where you have younger population, where are you most likely to find them? Where's the right platform? And we use trusted platforms such as faith centers, cultural gatherings, WhatsApp, community radio, and all of the whole gamut that you can think about in terms of platforms. We've also provide grants. We provide grants as much as we can to support local organizations to lead the engagement, because again, local leadership creates lasting impact. So everything we do is grounded in the principle that people listen best to people they trust. And on that note, I'll hand over to Coyote to continue.
Yeah, thank you, Abby. Yeah, my name is Coyote Fadina, the Health Inequalities Project Manager. So I know I was introduced as a personalized care program manager. So I used to work in that role, but I at least have transitioned to this particular role at the moment. So to look at our approach generally, Abby has mentioned and talked about the barriers. And then our approach more or less shapes how we address those barriers. One of the major areas of barriers, we have the language and literacy, for example. And then because we know people access and process information differently. So as a result, we look at how we address those intimidating languages, for example, intimidating medical languages, for example. When we look at people to have a PSA test or prostate-specific antigen test, within some groups or communities, it's a thing that scares, but when we go into such community, for example, we talk about having your blood test done to ascertain your prostate health, the message resonates.
Oh dear, seems to have frozen. Abby, can you carry on in the meantime?
Can you hear me?
Yes, you just froze for a few seconds. Just carry on, that's great.
Oh, okay. Yeah, so, and in that sense, we try to approach issue of, for example, language and literacy by looking at how we break down the information in a way that is friendly and then relatable. For example, in delivering such, for example, we look at the messenger, the platform, and the message. For example, trying to deliver information about process screening, for example, we could use the platform of the mosque or the church or community setting. And the messenger could be someone within that community, maybe a trained professional that comes from that particular community to deliver such message. So apart from addressing the intimidation of language that goes with such medical term, but getting someone that breaks it down and deliver it to them in that particular setting goes a long way to addressing those barriers. Another approach we've been looking at, for example, is the cultural and religious preferences. We know within some religious environment, talking about certain illness or privacy-related illnesses like cervical or penile cancer and other related cancers could be so sensitive. And then, for example, we could get a male faith leader to introduce men's related penile cancer, for example, to the people, but to get someone within that's a professional to talk with it. So that helps to break down the cultural and religious differences compared to someone that is out of that community, just coming in there to deliver it. So working in collaboration with such a religious leader, for example, goes a long way. And then that's more or less part of the approach we used in delivering messages within certain communities. As well, I will talk about awareness and accessibility as one of the issues. And then in our approach of addressing such, for example, it's not just awareness, it's not just about people knowing, it's also about knowing what to do next and feeling safe to act. And in doing such, for example, we look at maybe community groups, or let's say LGBT group, for example, and where they have their gathering or events, and get someone that maybe a professional within that group to come there. So the platform will have the LGBT group setting where they are delivering, maybe having their event or annual meeting or whatever. And then the message is to see how they address awareness about maybe certain type of cancer, for example. And then we use that to deliver the message through those settings. So the message platform and then the messenger thing goes hand in hand, and we consider the environment and the setting when we want to address such in communities. And then going further, we're looking at how we approach it. We talked about that, and then we're looking at what drives our approach. And that's more or less where we have the issues of the Core 20 plus 5 principle coming into play. We know the Core 20 plus 5 principle is about national approach that was driven to address inequalities in areas of health conditions. And we have adapted these to a local level of cancer. The Core 20 approach is to look at the 20 most deprived areas, because evidence have shown people within those communities are the ones that experiences a late presentation, that have low level of awareness about signs and symptoms of illnesses. So in that instance, we localize our own approach to look at the Core 20, the most deprived 20% areas of TVCA covered region. And then we're looking at the plus people, which are the people that are the targeted population. I mentioned earlier on, maybe we have the migrant communities, we have the BAME communities, we have people with language barriers, people in rural isolation, and LGBTQ, or people with neurodivergent conditions. And then the 5 areas we are looking at mainly are the area that we have seems to have higher population of incidences between skin cancer, breast, bowel, lung, and then prostate. Of course, we still cover other areas of cancer. You have an awareness session for head and neck cancer. We still deliver events relating to that, but these are the core areas we focus, because this is where we have the higher population of people mostly affected. And then as well, apart from looking at it from Core 20 plus 5, we also operate on principles of proportional universalism. This is just ensuring, not just ensuring everybody have access to awareness, screening information, but as well we tend to focus with greater intensity and approach to people that are experiencing inequalities. So these two, Core 20 plus 5 and proportional universalism, work together hand in hand, because one seems to identify where the problems are, it tells us where to go. The Core 20 plus 5 tell us where to go, and why the proportional universalism tell us how we can deliver those support that people that need it the most. Because if you look at the diagram below, we know most certain we are at the reality stage where we just deliver one size fits all in most services to people. And we could see someone not even, they are so tall to the point they can't see anything. And then we have some people accessing, And then even at times we tend to provide equality and provide the same services, it still doesn't solve the problem. Equity seems to provide equal balance by providing needs for what everybody needs, and then people can see maybe the game in all equal measures. But having said that, we need to be moving to the inclusion. That's where we have the co-production element in the area of our work comes in, because people are part of the problem, they're part of the solution to the problem they face. And that's more or less general approach of our work in addressing areas of identified inequalities. Now, for the sake of our time, I won't break this down further, but to move on to, I'll say the next slide. Okay, yeah, so I know we have been a bit over time, so just to quickly run through this. Our expected impact is to increase awareness and symptoms, and let's drive more less of our community engagement activities and promoting awareness and symptoms, having events with community groups, try to increase uptake by, once people have awareness, we promote
Sorry, I think Kylie is gone again.
earlier diagnosis.
Oh, she's back. Karen.
Yeah, so, oh yeah, sorry. So we're looking at if people have early screen uptake, it will address it will address reduction in late cancer presentation, because late presentation, of course, the outcome is not always very good. So front end work is awareness, improving screen uptake, encouraging early presentation for diagnosis, help us address late presentation. And as well, our work as well is to target improving trust and in the system, because that is part of the problem where we have low engagement with the system. So I'll say our key message is to have equality where we give everyone the same message, but to still move a step further to have equity by ensuring people that now need extra support get those. And then more or less where we have our Cancer Alliance model, which we not only focus on fairness, where we have everybody to have the same thing, we still work in partnership with groups, and then we ensure we try to promote to address earlier presentation, early diagnosis, and better experiences for patients. Finally, just to say, just to show some groups we have worked with over time, where we had events or funded some projects with them and the rest. These are some of them. They range from religious to community groups to non-profitable groups and the rest, even to NHS organizations. And these we have been working with over time, and we're still trying to expand the scope of our allies. So I'm using this forum as well to see that we're still looking out for groups, allies that want to expand and work with. So we want to ensure the breadth and scope of our reach touches every corner of areas of people that needs to be heard about cancer. I will bring this to the last slide, which is just questions. Apologies if you run over time, but then it seems to have a lot to pack in.
Thank you both, and thank you all. That was really interesting. I think we spanned from the sort of very homely care that Maggie's provides in a particular place to the sort of wider, really important work of tackling those persistent health inequalities, and that co-production with communities that's so important to get that tailored healthcare there. I'd like to hand over anyone who has any questions. If you could put your hand up, or you can put questions in the chat. I can't see any questions at the moment, but I was interested in the work of the Thames Valley Cancer Alliance, and just if you had some examples of work you've been doing with groups in Oxfordshire would be interesting to hear, because a lot of those examples on the screen were from the other areas.
Okay. For example, within Oxfordshire, I think we have delivered learning disability event in the past. Having said that, within all the areas, Oxfordshire seems to be the area we struggle to get allies. We have tried and tried, and then we've communicated. So the only group I would say, mainly within Oxfordshire, with the we have a Nigerian community in Oxfordshire we have worked with, and then I think on occasions for about some years back now. But having said that, we've always been trying to see groups we could work with, apart from primary care, where we funded some projects. We've been trying to look at groups, community groups and the rest to work with within Oxfordshire, and then it's been a bit of struggle. So maybe this avenue could be one of the areas where they could help us cascade our.
Yeah, also recently we did do some work with a local church. Actually, actually the work spanned across Oxfordshire, Abingdon. I think there was Abingdon, there was Bicester and Oxford. So we did it. So we did around between December and January. We did some cancer awareness engagement with that church. But like Kayode said, I think we find that what we find over the years is that particularly Buckinghamshire, there seems to be very well established groups, particularly community groups in Buckinghamshire, most especially than we've seen in other areas.
As well as Swindon.
Yeah, as well as Swindon. Swindon and Buckinghamshire seem to be well established in community organizations. Yes, but we've done.
Okay. I think there's a lot of us on this call and elsewhere who can help you with that, because there's a huge amount going on in Oxfordshire. There's already work around prostate awareness with Black African men, and we've just been working with one of the groups, Sunrise Multicultural Centre, on cancer with the Asian women's group. So there's a lot out there with community groups going on. Any questions from the audience?
I've got one, Veronica. It's in terms of the diverse community, sometimes when people have cancer, it's sort of very taboo and people really don't know how to deal with it. And I think that sometimes people that have experienced that could go to the groups to promote it, not to promote it, to say, you know what, this is what happened to me, this is how I went through it.
Yeah, I think, yeah, you're right on that. I think one of the projects we delivered in Aylesbury, the Caribbean Community Lunch Club, the approach was to get someone that have gone through the system. They had the condition, and then that person is the one that will be the focal point to do the presentation, to talk about their experiences. And that, of course, have a far-reaching effect. But then, having said that, it's still a problem to still get people within certain religious and ethnic communities to even come up to still want to talk about it, even though they have experienced it. Because if I have to cite an example, where people doesn't want to, they feel, well, if someone knows someone within our family have had this type of cancer, it could affect someone within the family getting a partner. That's, I don't know how that linkage work, but I've seen experiences or examples of that where they rather keep it within the family instead of. So even if you have the approach of getting someone that have gone through the system or the treatment or the pathway and whatever to come and talk to people, that person may still feel, I don't want people to know. For example,
Oh dear, frozen again.
Yeah, I
Yes.
suppose it's ongoing for us, isn't it? And you're
Yeah.
quite right about that. And that's the key thing about working with community organizations, because within the communities, and it's also the destigmatization of cancer,
Yeah.
isn't it? That's part of the work we do to destigmatize it. That it's something that can be talked about. So it's an ongoing work. So one of the things we do within the work is also that psychological aspect of cancer as well. So it's not just about people not knowing about signs and symptoms. Sometimes it's about people not wanting to take action. So it's not only about increasing awareness, but it's always about opening up about cancer, making it not to be that taboo subject. That the more we talk about it, the more it becomes, it's not a taboo subject. It's a subject that actually, like we said, early diagnosis saves lives. And if you've gone through it, your valuable information can help another family. So by consistently passing that message across as well. And I think the important thing is also by working with organizations like Maggie's, Healthwatch, because you deal with that on a daily basis. And so it's about how do we tie all of that up to help our population.
Thank you. Another thing I was focused on, because I can't see any questions still in the chat from people, but was around prevention for cancer. And I know, in Oxfordshire, there's a huge amount of work going on around physical activity, the eating and stress management and that sort of thing. So do you tie in closely with the prevention work that's going on in the county, or refer people?
Yeah, we do. In as much as within cancer alliances, prevention is not actually a program of work within the alliance, but our program of work is early diagnosis. But we recognize that prevention is, as an example, screening. So we recognize the importance of that. So what we do is to tie in with other organizations, like we work closely with the public health team, and to see how we actually bring that into our work with the communities. Also signposting. So even if you're not doing anything actively around that, it's also been as part of those activities, it's also signposting people to the right teams and making sure that information is available for the people we're talking to. Yeah.
Thank you. I can see that Anna wants to ask a question. Anna, would you like to ask your question?
Hello, I started to write, but it's better to ask. It's just because we are running monthly support cancer cafe in Farringdon, and we are planning our meetings for next year. And maybe there is, you can share some contact details. Maybe if we have request for people, I don't know, maybe people want to speak about like psychological support or other maybe types of cancer. Maybe we can ask somebody and invite like speakers for our meetings. So if you can share maybe your or Maggie's, I personally want to say great. I'm really grateful for Maggie's center, because I visited with my husband when he had cancer. So, and it's really amazing space, and we hope we will have more spaces like this in Oxfordshire and everywhere. So what is the problem I feel with our support cafe in Farringdon, that it's like monthly, we have like 1 hour or so. So it's not, we can't follow people's needs and their availability and good times for them. So we can suggest like once a week, once a month, but it's not always convenient for people to go to this space. So but anyway, if somebody can share like some details, who is happy, maybe you can suggest some talks that you're already doing for communities, and we can invite you for our cafe. It would be great. Thank you.
Yeah, we will do so. Yeah.
You might like to put your emails in the chat, and people can contact you directly if they were interested in inviting Maggie's or Thames Valley Cancer to them. I know there's quite a few patient participation groups here online who'd be interested as well.
I'll put the Maggie's email address in. Yeah,
Lovely.
that's absolutely
Thanks.
fine.
Mike, do you want to add anything to the conversation we've been having a bit more around Maggie's and the work you do, or how
Yeah,
people access it?
I think we're aware that access isn't equal, you know, across all different groups, whether that's gender or race. There's, you know, I think there are issues around, you know, getting different people into centre. You know, we're looking at the moment, looking at starting up a men's group is one of the things, because I know we probably underrepresent some of the men. You know, in the centre, we're probably more women attend the centre. We also know that, for example, fewer young people with cancer sometimes attend the centre. So it's like trying to work with the trust on where we might be able to do some work. I know in London, in the West London Centre, they've done some work with the Chinese group, and they one of the Chinese community groups runs some work out of there. So I think there's still work to be done. You know, we won't be able to do it all in one go, but I think there is something about meeting with the groups and finding out how can we make sure Maggie's is accessible. In principle, it is, but it doesn't mean everyone comes there. I think there can be a reluctance to go through the door. We're doing work with the teams in the hospital to try and really not have that gatekeeping, but that really Maggie's is for everyone. And it's not about someone who's very anxious or very upset, but actually anyone with a cancer diagnosis can benefit from accessing Maggie's. And then, you know, we obviously have our specific cancer support groups, a number of them run out of the centre, and that can be a great way, you know, to engage with the community. You often have really strong advocates within their specific groups who run these groups that we work with. But certainly, I think we are, in principle, also happy to go out and talk to other organisations and to meet with groups if that would be helpful about how we could work better. You know, we've been quite short of staff recently, but we're fully up to complement, hopefully from beginning of January. So that might give us some space where, when we're not busy directly supporting people in the centre, we can actually do a bit more outreach work as well. So if that works, we could certainly be really happy to engage.
So any other questions from anyone? I can't see any.
It's Tracy.
Tracy, would you like to ask a question?
It's more really a comment. I just for people's knowledge, I am a trustee with Healthwatch, and I'm particularly interested to find out about what's going on locally with the services that are available. I'm really pleased to see what the finished Maggie's looks like, because when I worked in the NHS, the plans were in place and work was going on, but I left before it was finished. So it's such a lovely space. I can imagine that must be such a soothing relief for people when they are able to enter somewhere like that and they've got people to greet them. I understand, you know, from some of the work that we've done with AMIA, when we talk to patients who've gone to the cancer centre at the Churchill, and it's quite obvious, you know, it's extremely stressful. So, you know, really thrilled to see what Maggie's looks like now, and good luck with the rest of your work, supporting people when they really need it. Didn't know anything about the Alliance, so that's been very interesting. Once again, hope that you manage to build up your networks further. Addressing issues which the NHS has struggled with is just so important, and I know that the work that you're doing is really dealing with something that we just haven't got to grips with as a whole system within the NHS and related bodies. And the graphic that you used to indicate equity and access, that was really excellent. Really like that. So it's just some comments and thank yous really. So I'll sign off now, but very good to hear from you all.
Thanks, Tracy.
Thank you. And I know Thames Valley has been working on some really good videos as well in different languages, I think. And I think we've got links to them on our website. So South Asian languages and other languages. So those are really brilliant ways of messaging. And you'll find them under our information page on our website. One thing I was just thinking about was all the publicity recently on men and prostate screening and the debate about that. And I wondered if Mike or one of you might like to just add a bit on that, because it's a bit confusing for everybody, I think.
I think it is, and so a lot of people come in talking about it, and I think this is an example of where I think Maggie's role is, if people have very specific questions around it, I think our role is to guide people back to, support them and empower them to ask the right questions, but to guide them back to their healthcare teams, to talk that through directly. I think, we cover a lot of cancers. We cover all cancers. So we probably try not to, debate that with people, but support them in the anxiety around that. There's a lot of anxiety. Should I have had a test? I'm trying to encourage my husband to have a test, my partner to have a test. And, we'll often, as I say, I think a lot of it is about empowering them to ask the right questions, finding out where accurate information is, and guiding them back to the healthcare teams for support. But when any of these things come in, any thing like breast cancer awareness, or the prostate cancer with Chris Hoy in particular recently, we get loads more questions around that. And that's great, though. People are being more engaged, and it is confusing. It's an area of debate, and it's an area of whether one should have a prostate test and what issues, when you should have that. It's not a clear answer, and I imagine GPs are probably being inundated with that sort of, people turning up for tests and having to have that communication with them about it.
And generally, I think the advice is, if people are worried, go and consult with your doctor, isn't it? Don't sit on it or talk to others.
Yeah, and we do a lot of signposting back to teams, and it's about people saying, well, I can't get an appointment. It's just trying to encourage and empower them, saying that make some space, do this. It's important. It's concerning you. You're worried about it. So.
Great. So that's been really interesting and useful. Are there any final questions that anyone wants to ask? I don't think I can see any. But thank you so much to all of our speakers. That's been really interesting. As I said, this will be on our website. Our next webinar in January, I've put it in the chat, is on neighbourhood health, and that's that move of health to be within communities, and it's understanding how that change is going to take place and how you can be a part of it. So keep your eye out for future Healthwatch Oxfordshire webinars as well. But thank you so much, Mike, and Abby and Coyote. It's been really useful, and we'll put all of the resources and the slides on our website and links to those organisations. So please do keep in touch, and have a good rest of your day. That's great.
Thank you.
Yeah, thank you so much.
Thank you.
Bye.
Bye.